Oh, Dr. Vikas, can you hear me?
Yes,
So
yes,
now
yes.
I would like to call to Ankit Gujjar. Please join and please welcome to all. And thank you
Okay,
so
sir.
much to
So
join
I'm
this
starting.
seminar. Okay, thank you so much. Please, Ankit.
Yes, sir. So now we are starting our session. Good evening, everyone. It's a pleasure to welcome you all to our guest lecture series by AIRSA. And on behalf of AIRSA, I extend a warm welcome to our esteemed guest, Dr. Vikas Kumar Tiwari, and all our attendees. Also, it's an honor to introduce our distinguished and renowned guest, Dr. Vikas Kumar Tiwari, who is currently a doctoral candidate under Neuro Global Program in Graduate School of Medicine, Tohoku University, Japan. Dr. Vikas Kumar Tiwari has done his MBBS from Government Medical College, Bhopal, and completed his MD in the Department of Physiology at AIMS, New Delhi. Also, Dr. Vikas Kumar Tiwari has a remarkable track record in terms of research output and publications and has made remarkable contributions in the field of pain research. Today, we are here to explore rTMS as an unconventional method of pain research, and there couldn't be a better person than him for this topic. And before we begin, let me quickly outline today's session. Dr. Tiwari will firstly deliver the lecture, which will be followed by the question answer session. And please feel free to ask any of the questions related to this topic in the chat box, and we will address those questions during our question answer sessions. We aim to conclude this session by 8 p.m. and we will ensure a comprehensive discussion on this topic. So, without any further delay, I invite Dr. Tiwari to share his insights on RTMS and its use in pain research. Okay, so over to you, Dr. Tiwari.
Uh, Thank you, Ankit, for your kind introduction. I hope I will do justice with this. Let me try to share my screen first. Mm, into entire screen. So, can you see my screen now?
Yes.
Okay. So, mm, I think you all be able to see my see my presentation now. Kindly confirm so that I can proceed. Like, can you see the first page?
Yeah, yeah, yeah.
Are you seeing the one slide or seeing everything? Like I started my presentation on presenter mode. So is it good?
Dr. Tiwari, your notes are visible, I think.
Okay.
Oh,
So I think I should go for the general system. So hello everyone. Greetings and namaskar. First, I would like to thank you, Dr. Lal, for being cornerstone of this Nobel ISA forum, which helps new scientists like me to ascend in their field, and also it tries to make a good environment for better scientific outcome and good research. In the same time, I would like to thank you, Ankit, my very good friend, and we did masters from AIMS in the same time. Now he is very aspiring doctoral candidate in AIMS New Delhi itself, and I hope he will do very good, and we all follow good science and proceed like this. So today's topic rTMS, that is repetitive transcranial magnetic stimulation. Uh, this is like how to say it is an intersection of neuroscience and clinical application. So today I will see how this method is becoming an unconventional method for pain relief. So without being a further ado, so let us see. So rTMS is not very new now. So it came maybe the earliest experiment started before 1800. So what happens? We'll see next now. So you can see, like even before 1800, it was discovered that all the excitable tissue, especially nerve and muscle, they have somewhat electrical energy. Later, they have performed some experiment to stimulate this tissue to see how they respond. We all know they are excitable tissue, so they respond to stimulus. Now later, magnetic field was used as a stimulus. We all are doing neuroscience. We know a stimulus can be electrical, touch, pressure, So later, magnetic field was used in animals, followed by same kind of experiment in humans. So in 1985, Professor A.T. Barker, somewhere in UK, produced a prototype device, and that was known as first TMS device. And in the same year, he successfully completed a stimulation procedure. And soon after that, there will be a release of safety guidelines by competent authorities. So you can see, within a span of 100 year or so, or maybe 200 year to be very precise, right from the beginning of the excitability of the nerve, and within 200 year, all the safety guidelines are also released. Soon, researchers like us started doing research to see whether TMS is effective or safe. And later, Canada will become the first country who approves the use of TMS in the therapy. Later, followed by United States. Sorry. After this, NIH, Dr. Lal is very aware of this kind of things. So he used to write nice funding for research. So he started giving the fund to start further research in effectiveness of TMS. Finally, we all know we have health insurance. Like in United States, there's Medicare and Medicaid, and in India we have Aishman Bharat and Chiranjeevi kind of things. So they also start covering TMS in the health cover also. So TMS therapy now is widely used and it is safe and effective. And it is interesting to know that depression was the first disease which was approved by the FDA for the TMS. So let us go by the subject in hand now. So whether you are a skeptic or supporter, I invite you to join this potential of the magnetic field and see how it is recreating or how to say channelizing the new patient therapy for chronic pain subjects. So this is the iconic image. This article was published on Lancet. You can see the 1985 noted here. So this is the first design you can see. This is Professor Barker himself, and he's putting this coil. And if you can notice that something is tied on the hand of the subject, we'll see in subsequent details. So this is the basic TMS system looks like. So can anyone tell me what is the magnetic field of Earth? Like you can guess. The unit of magnetic field is Tesla. So what do you think? What could be magnetic field of Earth? Anyone? Yeah, you can guess. So okay, let me tell you. So it's a 50 microvolt. So that means of 1 Tesla is a complete unit, and the 50 microvolt, 50 micro Tesla is the magnetic field of Earth. If you want to compare the standard MRI machine across the India or Japan, anywhere, they used 1.5 Tesla, and the TMS uses 2 Tesla. So you can see this magnetic field is so strong compared to the Earth magnetic field, and it is even stronger than our MRI machines. And the pulse width is 100 microsecond. So we all know the basic physics of wave. So it goes like this, up and down, crest and trough. So width of one pulse is like 100 microsecond. Now let's move further. So I know it's a little crowded slide. Let's go from the right side. I'll help you to navigate from here. Let me pull up a pointer. Yeah. So this is a simple monitor, or we can replace with our laptop or computer. This is kind of graphical interface, like people know the programming. So it is a coding kind of thing. So we have a graphical interface also. Sorry for interruption. So just after this is a stimulator, and stimulator has a main device. It houses all the equipment which produces the high ampere current which goes directly to this coil system. So this is a coil. This coil having high ampere current, and this produces the magnetic field. We all know the Lenz law. The changing current field produces the magnetic field. This is the principle. This is in elementary school physics. Now, what happens is this machine produces the high amount of current that is fluctuating, and this will in turn converted into the magnetic field by the coil. And now this coil will be kept on the skull. We'll see further. Now, this is a simple chair. This is an ergonomy designed for the better patient care, and it helps to patient relax and get therapy. And everything is same written here also, like this is the magnetic field. And of course, very important thing, this coil is equipped with the cooling system. Of course, we all know when energy form is changed from one form to another, the most form of energy is wasted in the form of heat. But this heat doesn't just decreases the efficiency, but also it will it can be a potential cause of burn or discomfort to the patient. So there's an inbuilt cooling system that keeps the temperature of the coil optimum, so that there will be optimum delivery of the magnetic field. Of course, it will having a software where we can record about the frequency, intensity, and the patient record, and how many sessions they have been, and how many remaining there. And let's see further. Now, this is the same device I used in my MD thesis, and Ankit kindly became my thesis subject also for just trial. So he might be remember all these things. So you can see this is NeuroSoft NeuroMS device. This is made in Russia. So this is the main TMS housing, which having this current production at high ampere level, and this will be sent by this coil. Okay, and this is the, you can see the software, and it can give the waveform. Now, let's see what is going on here. You can see this subject is putting a cap here. Consider cap as a physical coordinate. Okay, so what happens here? You put the coil on the scalp by designated area, like I stimulated the dorsolateral prefrontal cortex, that is DLPFC. Per most of the study was done on the motor cortex. So there's a 1020 EEG system, so where we can define the location of motor cortex and later confirm by producing the twitch in here in the thumb muscle, also known as abductor pollicis brevis. So see, we don't have to do this exercise again and again every time the session is repeated. We just mark on this cap the outline of the coil, and it is marked such that the center of the coil lies on the motor cortex or area of interest. So as you might see, this is a non-invasive technique, and it doesn't involve any surgery or anesthesia. So this is the very beautiful thing about TMS. So in our quest of pain relief, TMS comes as a paradigm shift, which leverages the neuroplastic potential of the brain and produces some change. We'll see this all jargon subsequent slides. Now, so up to until what we know, so there's some device. It is made in 1985, and the first model was made by the Professor A.T. Barker. And what it does, it simply sends brief magnetic pulse, and what it uses, high voltage current, and this fluctuating current produces the magnetic field based on the Lenz law. And since it is a transcranial device, so of course it has to be kept on the head. So there's no point to guessing it. And it stimulates the cortical area. So what happens there? So depending upon the area of interest, whether you are interested on motor cortex, the most common one area of investigation, or you wanted to connect with the dorsolateral prefrontal cortex, or some people also stimulated the somatosensory cortex. Depending upon the area of interest and the frequency of stimulation and the intensity of the rTMS, results vary. That depend what you want to achieve, or just you want to see the effects, or you want to cure a condition. You know, the difference between neuroscience and clinical application, like this kind of thing. Now, let us know a little physics behind it. So first, what happens? Number one, this is the coil which carries high voltage current, and you can see this coil is in figure of 8. So you can see if current goes like this, at this point, this both coil having the same direction. So we all know this will follow the vectorial addition, and this is the point where both arrow are like this. So this is the center of coil, and it must be kept on the point of interest because it was proved by the simulation techniques or the physical experiments that the area of interest should be lie before this coil so that it receives the optimum stimulation. Okay, now the current goes like this, and we all know from the again physics that the direction of induced magnetic field is perpendicular to the current flow, like this magnetic field will be like this. So consider this a coil, a magnetic field will be surrounding this coil at a 90-degree, and we all know from the basic physics this magnetic field can produce the eddy current. We all know the humming sound produced in the transformers nearby and everywhere in Japan, also in India, because what happens when magnetic field is produced and it goes to solid conductor medium or any medium, so it having some vibration produced by the electric current produced known as eddy current. Okay, so this eddy current is a pivotal force or the motivating force that produces the actual changes. So you can see the irony. Even the TMS that used to be magnetic stimulation, ultimately current is the working force here. Okay, not the magnetic field. So this current is the parallel to coil. So the current and the magnetic field is perpendicular, and this current is parallel to coil. That means it is the coil should be kept at the 90-degree to the brain center. Okay, so that it can produce the optimal input. Now in this image you can see this is the magnetic field, and with it parallel to the this is the eddy current, the current which produces the effect, and there's 90-degree angle between the axon. So this is the optimum setting. That's why the coil should be kept uh, like this. If people are interested, okay, what will happen if the coil will be not kept like this? It will be parallel to skull. There will be no effect because very less amount of magnetic field will be crossed to the skull. So less amount of eddy current will be go to the skull, and less amount of axon will be stimulated. Okay, even though in some setup, if there is no SAM coil, they just keep the coil like this standing position, but patient is unaware what should be the optimum position of this coil. So he or she feels that okay, we am going to the therapy, and we can record the effect of SAM treatment or placebo treatment by this method. So recapitulate, there are electromagnetic pulses, they are brief, and since the current is alternating current, so magnetic field is following the same pattern, and this will produce the eddy current, that's induced electric current, and this is the motivating force, driving force to produce the stimulation of axons of the cerebral cortex. Now, like anything, like any chocolate or any cookies or maybe countries also, there are so many types. So one is single pulse TMS and another is repetitive TMS. So we'll be focusing on repetitive here, but single pulse and repetitive, they are part of each other. Like when single pulse is repeated, it will be repetitive. As simple as that. So let us see, before going to detail, what happens actually. So this is the TMS coil, and till now we all know this is a figure of 8 coil. It is very intuitive to see. So this is kept at the primary motor cortex M1. Okay, and this TMS coil stimulates the primary motor cortex and indirectly activates the upper motor neuron. Okay, why indirectly activates? Because we are not activating the upper motor neuron by the synapses. They're getting activated, and they go by the corticospinal way, and upper motor neuron finally stimulates in the tandem to the lower motor neuron. Lower motor neuron takes all the signal to the neuromuscular junction. Neuromuscular junction spread this thing in the muscle belly, and muscle will follow all or none, and they will recruit the motor units. And after this, when the motor units will be involved, they will be having contraction as usual, and this contraction will be either can be visualized by the simple twitch. So my when I was doing MD, so Dr. Sumant Tawar, she used the experiment and she used the motor cortex as an area of interest, and she recorded the movement of the thumb. So what she used to do, she just stimulate the motor cortex from very low value of stimulation till she receive the threshold value. And how she know it is threshold? She just notices the movement of thumb. So this is the one way. But we all know this is having a subjective bias and error also. It is very difficult, and there is no proof of this. So what is better? We should put some EMG electrodes and let the electrodes record the EMG. That is the objective evidence of muscle contraction. So in my thesis, it was revised, and instead of watching manually and recording just on the memory basis, we started recording this thing on the EMG electrodes. Simple thing. So thumb movement can be seen like eyes, like you can see like this, or I can put electrode and show the recording. Same thing. Now, this EMG or electromyogram are known as motor evoked potential. So it is also intuitive. Potential, because it's a potential, of course, voltage difference, and evoke it is done by something else, and it is a motor response. So there must be something in your mind. So is there any sensory evoke potential? Yeah, it is. We'll see in subsequent slide. Now, with all the knowledge we gain, let us see how a simple TMS pulse or single pulse works. So let me navigate you from this. So we all know this is that here we have TMS device which houses the all the current system and produces the current with high ampere and high voltage. Later, this current is passed through this coil, and this coil has the current which is fluctuating in nature, and that produces the magnetic field. This is again in turn is fluctuating. So this magnetic field generates electric field in underlying cortex. Why? And this cortical area depend upon our interest area. So this figure of 8 coil is kept on the skull. Below the skull, we have some cortical area. This cortical area will having the stimulation from the eddy current, and this eddy current will produce the action potential, and that will descend to the upper motor neuron, and this upper motor neuron will carry the action potential to the lower motor neuron. Lower motor neuron will go to the neuromuscular junction, and then muscle will contract. And you can see here we have electrodes on the target muscle. So in this case, in my case also, I used abductor pollicis brevis muscle to record the EMG. Now, let me navigate you to this screen. So this screen is showing the simple EMG. Just forget the fancy name given to it. It has an EMG, electromyogram. So of course, x-axis is having a time, y-axis is having intensity, and it is recorded here either in ampere or volt. Usually it is recorded in the microvolt, and this is the amplitude. Okay, so you all know any current can be recorded in the terms of voltage or current. So usually they record in microvolt, and since a single pulse, so we'll produce single pulse. So what we can do, either we can switch the on off machine, and we can switch the machine button on this device. After this, what happens? There is the propagation of the pulse. Since EMG is also recording electrical activity, and this TMS carries the high voltage current, and and later this will produce a magnetic field, which will produces a noise or disturbance in the EMG recorder itself. So this is known as pulse artifact. You know, in classical neurophysiology, we all are recording, like Dr. Lal is very pioneer of recording from rat models for the sleep. So whenever we stimulate any any organ or any neural tissue. So what happens? The stimulus artifact is itself a sign of stimulation time. So of course, is artifact a mistake, but it can tell you exactly about the what is the time or t is equal to 0, the stimulus is given. So you can see it after stimulus propagation has to travel all these things. So there must be some latency because there is neuromuscular delay and the neural delay from upper motor to lower motor. So this will produce some latency. Latency is nothing like after any experiment, if we give stimulation, like in simple muscle twitch experiment, it will take time to start the muscle contraction. This is known as latent period or latency in this case. MAP is the same thing, motor evoked potential. So what you can see after this latency period, there's a wave comes which go up and goes down. So in again in electrophysiology and neuroscience, the direction of the peak is depend on the direction of your electrode. So from which electrode you are recording, that will change the direction. Okay. So it means nothing. Like if I change the direction of electrode, it will be reversed. So in any wave, this peak to peak is known as amplitude. So see why this is very good method to investigate muscle movement, not the thumb twitch, because we cannot quantify the thumb movement. Okay, no one can tell whether the movement was good or bad. We can just see quantitatively. Okay, I saw the twitch. That's it. But here in EMG, since we have the numerical value, so what we decided, it was decided that not I myself, it is already decided by a very great scientist that if this amplitude is more than 50 microvolt, okay, you can see the unit here, microvolt, then only it is defined as a motor evoked potential. Okay, learn this concept very carefully. So we'll stimulate the brain here in the motor cortex. Motor cortex will be stimulated, and this axon will be having some action potential. It will go to upper motor neuron, then it will go to lower motor neuron, and this will go to neuromuscular junction. And what happens? This will produce the muscle contraction, and after brief latency period, we can record or visualize the muscle contraction. And of course, in the same time, when we see the EMG record on the computer screen, we can see the thumb movement also. If you follow up to this point, let me slip a very simple concept. So here we are recording is evoked potential, and I didn't tell you what intensity and what I'm doing here. So in any machine, the intensity of magnetic field is given as MSO, magnetic stimulator output, or maximum stimulator output. Both words are used. So let us see, it has 100% value. Of course, maximum output will define by 100% of magnetic field can be given by the computer system, and the 100% value we'll see this twitch. So after putting the intensity 100%, we'll gradually change the intensity here. Like MSO is unit of machine itself, and we can further regulate its stimulation. So after this, we can see at what percentage we can see the threshold. Okay, and that is known as resting motor threshold. So resting motor threshold is defined in terms of maximum stimulator output of machine. Follow me on this. It is very crucial to understand. And motor evoked potential is simply the microvolt of EMG response. Both are different things. So motor threshold or resting motor threshold is the percentage of maximum stimulator output in which we'll having a MAP. And for defining MAP, it should be more than 50 microvolt. I know it's little much to grab, but I think it is easy. I'll explain it again. Now, after this simple pulse TMS or simple TMS or single TMS, what happens if we repeat this single pulse TMS after each 1 second? So of course, no point to guess. It will be 1 Hz rTMS, that is repetitive transcranial magnetic stimulation of 1 Hz. That is In neuroscience, it is defined as a low frequency. Usually 5 hertz and more is considered as a high frequency, and below this 0.5, 1, 2, they are low frequency rTMS. Okay, when the repetition is done 5 times in 1 second, it will be 5 hertz rTMS, and so forth and so on. Okay, now there's one phenomena known as paired pulse rTMS. In pair pulse, 2 pulses are given in series and they'll gap, then 2 pulses, then gap. So you can see there's a two-way. One, we have constant train of the pulses, and then we have the pair pulse and the gap, pair pulse and the gap. This is the thing we will be going to in today's talk. Just as an anecdote, there's other ways of stimulation of neural tissue. In neuromodulation, we can also use theta burst stimulation, that is TBS. Here C is continuous. You can see the continuous stimulation here. And another is ITBS, intermittent theta burst stimulation. So for 2 seconds, it is stimulated, and for 8 seconds, it is stopped. Then again, the cycle is repeated. So you can see it is intermittent. It's a no big thing to know. Now, let us see the pair pulses. So everything is same. The software, we define the distance in the terms of time between 2 pulses and the interrupted interval. So let me go back again. This is one stimulus, this is one stimulus. Okay, so this duration is inter-stimulus interval, that is ISI. And if we go by this, will be the inter-stimulus interval ISI, and this is another train of stimulus. It can be more than 2, of course, but it won't be then paired pulse. So it will be train. So this will be inter-train stimulus. So here 8 second is inter-train stimulus. Okay, let's go to back to next slide again. So first we give a conditioning stimulus, then we go to test stimulus. So this is the control motor evoked potential after giving the test stimulus. This is latency we just now. And of course, we know this in this point, we'll be having the pulse artifact or stimulation artifact to be in general language. And you can see 0.5 millivolt is as good as 50 microvolt. And then intra-stimulus interval is 2 millisecond. And then again latency. And then you can see inter-stimulus interval is 12 millisecond, then again latency. Can you notice one thing? When inter-stimulus interval is less, that is 2 millisecond, the latency followed the peak followed by the latency is decreased. Can you see this? And when the inter-stimulus interval is more, that is in neuroscience, the more or less in millisecond only. So don't go by the general balance. So it is increased. We can see how this is very unique phenomena. That if we give 2 stimulus, depending upon what is the delay between 2 stimulus, it will change the outcome of motor potential. See how beautiful this response is. So my Japanese professor used to give me analogy. Consider brain is having its rhythm, like in opera or orchestra. We all know brain works by default mode network, DMN. So after this DMN, TMS is kind of noise. Like if you are singing a song, if you are singing a song, somebody disturbs by a strong band like this. So every time it will produce disturbance, sometime it will disrupt also the ongoing music. So TMS is that disturbance. So brain is having their own activity, they're playing in on music, and TMS comes as a disturbance. But this disturbance, nothing like any other disturbance. It has a deep mechanism in the physics and the neuroscience, and how much intensity and how frequently it is given, the frequency and intensity both comes into the play, and it will alter MAP response. And till now we know that MAP is just a surrogate marker of cortical excitability. So something must have done already in cortical matter that is reflected in MEP. Okay, like if I am getting a flight to some other country, so it is evident that I have already got a visa. Okay, this is not possible that I'm going somewhere I'm not having visa. So getting a flight is surrogate marker, but definitive proof is having a visa. So in pair pulse, if we have the short stimulus interval like 1 to 4 millisecond, here they have 2 millisecond, it will cause intracortical inhibition. We can see this here. And if it is like between 7 to 20, in this case it is 12, it will having intracortical facilitation. So I hope up to this you are following me. Now let us go further. So we all have in our mind, okay, Dr. Vikas, we saw this device and we know, okay, what happened and where's paradigm of TMS, but how it works, like what could be the potential thing, like they can alter the cortex and the neurons, finally they're reflected in the motor potential. So starting from the simple things first, mechanical stimulation of the skin receptor. So we all know every skin surface has some receptors. So if we touch like this, or if we put a coil, of course it will stimulate the receptors. So vibration receptor or touch receptor, sometime pain receptor, although there is no pain response. But yeah, you can see, of course, this all sensory input will go and affect the brain somehow. I think most of will us agree to this, that this stimulation, apart from neuroscience, simple mechanical stimulation of the skin is there. Just 1 second. Now let's go by this. This is what I discussed on the skin surface. Up below the skin we have the skull. Below the skull we have dura. Below the dura, we have arachnoid. Arachnoid, below the arachnoid, we have pia mater, and it adheres firmly with the brain. So this is simple anatomy. So what happens there? This stimulation, mechanical stimulation, like putting a coil and having the magnetic field and some temperature effects, some vibration. So this will stimulate the receptor and magnetic stimulation of the myelinated axon here in the dura mater. Of course, here we are having the afferent axon and the raffinil-like receptors. So first it stimulated the skin, later they stimulated the myelinated afferent axon and the raffinil-like receptors. Last but the not least, if anyone went to the TMS experiment or even went to the MRI, for any diagnostic or research control subject in neuroscience, it is very pet. Like if I been to subject of Ankit for 25th channel, 25 2050 sorry 256 channel EG recording, then he has to be my subject for the TMS. So this is how neuroscience work for the control. So I been for EG recording, and I also been for fMRI these things also. So it has very harsh but not very loud, a click sound. Every time that pulse is given by the machine, it gives a click sound. Of course, this sound conduction will occur to the ear, both from the air conduction and bone conduction. And we all know inner ear is the part and eye is the part of brain itself, the extension of the brain. So it will somehow stimulate or alter the brain sensitivity or modulation. How it affects the brain is beyond this slide, but you can see there's so many possible mechanisms how TMS works. Now let us see. Now let us go into further detail. So we have covered the skin, we have covered the dura mater, we have covered the auditory stimulation by the ear, whether by the bone conduction or the air conduction, the main conduction. Now, MEP, we just discussed motor evoked potential. So what happens? So there are a mixed kind of neurons like sensory neuron, motor neuron. So orthodromic excitation of the somatosensory axon produces the somatosensory evok potential. So orthodromic is very elementary biology. So what is direction in the natural field or nature or the original physiology? It is orthodromic. Like if we have a axon, so what is orthodromic from dendrite to here axon terminals? This is the normal way of pulse propagation, you know. So in TMS itself, this is the direction of the stimulation. And if same happens with the motor axon, so it will having the it will produce the twitching, which can be recorded as EMG response and which can be visible from the naked eye also in the terms of thumb movement, and produces the motor evok potential. Yes, just 1 second. Uh, so this is how the motor response can be recorded and the sensory response can be recorded. So someone can see why it takes so much time and why the TMS therapy prolongs even followed by the stimulation. What happens when there's magnetic field? It is having the long-term potentiation and long-term depression. We know these two types of synaptic changes depend upon the frequency of stimulation. So it will further cause the modulation of neurotransmitter release and change the synaptic plasticity. And this combined effect is known as dynamic system theory that will cause the long-lasting therapeutic effect of TMS. And apart from this, a magnetic field, a simple humble magnetic field having its macromolecular magnetic effect, spin effect, quantum effect, and genetic magnetoreception that will change the genetic apparatus. Maybe it is a neuroprotection for the glial cell, and it will nourish also to neurotrophic effect. So what we covered now, neuroplasticity, neurotransmitter release, and the stimulation of targeted area like motor cortex or DLPFC, and this will modulate the circuits. And all this having the various application in the pain, our main topic today, and the cognitive function and other psychiatric disorder, neurological disorder. And simply, apart from other pain and psychiatric disorder, you can see the migraine, headache, stroke rehabilitation, anxiety. There's wide array of psychiatric and neural disorder can be covered by the TMS, and they are proved to be effective and safe. Now, what is pain? IASP, International Association for the Study of Pain, define pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So we feel bad. This is the pain. It may be actual or it may be just potential tissue damage, but this is the pain. So it is different from nociception. So let us see how pain is relieved from the TMS. So primary target is motor cortex, and as a rule of dictum, the stimulated side is contralateral to the pain side. So it is simple. We all know the motor neurons decussate and go cross to opposite sides. So if I have limb pain on the right, will stimulate the left and vice versa. But in generalized pain like fibromyalgia, we used to stimulate the non-dominant limb center. So usually in all the patients, the right hand is dominant. So I stimulated the left. I didn't stimulate the left because it will affect the right hand, the dominant one. So I stimulated the dominant brain, non-dominant brain, sorry. Usually this effect lasts for the 1 year, and sometimes they need a monthly maintenance. And apart from motor cortex, DLPFC and S2, that is somatosensory cortex, they are areas to be stimulated. And apart from figure of 8 coil, we saw there are other coils also, like circular coil, figure of H coil, you know, so many. And it was seen that high frequency stimulus is better than low frequency, but in my studies, I found otherwise. And apart from the TMS, we know the TVS also, theta burst stimulation. So high frequency stimulation on the motor cortex is known as best pain relief mechanism. And of course, it relieves the pain compared to control. And normally the FMS, CRPS, that is complex regional pain syndrome, neuropathic pain syndrome, they all based studies. And of course, rTMS means consecutive sessions, not once. So usually with the repetition, it is improved. And this is the few of paper I have published. So I will explain the result in short. So I have stimulated the dorsolateral prefrontal cortex, that right side one, and I have found significant difference in the reduction in the pain. And though it is a low frequency and not motor also, though we have found significant difference, that means it is not well understood till now why how the DLPFC also decreases the pain with low frequency, because earlier it was told that motor cortex with high frequency is best for the pain relief. And I also found the sleep cognition is also improved, and I didn't find any change in MEP records. So usually the results are peak of patient tell us that within 1 week they feel so good about it, and you used to repeat the therapy for the 4 weeks. So in my protocol, 5 times a week, and that to the 4 weeks, that is 20 sessions will be given. And cortical excitability usually correlate with the pain response, but in my study, I didn't find any change in the cortical excitability. One more detail, that in pain, we have 4 domains like sensory pain, affective pain, emotional pain, and miscellaneous pain. So they say that affective component is most, how to say, improved in patients. So it means that it also affect the affect disorder or limbic system and periaqueductal gray areas also. If I do this same experiment in animal model, the work I do in Japan, so I use the experimental pain by the cold temperature or the electric pain models. Usually, uh, unilateral rTMS is applied, of course, the contralateral to pain side, but of course, it is not strictly somatotropic, that the effects are diffused. It is not said that if I put the coil on the opposite side, there will be no effect. It was seen in FMS only and myofascial pain syndrome that both unilateral bilateral stimulation shows efficacy. And this is I just told bilateral effects. Now, the it also affects the descending inhibitory controls, that is periaqueductal gray area, that is very pivotal in the pain modulation system. So animal studies is done on the non-human primate, like in Japan. I am doing on the Japanese macaque monkey and also on the Vistar rat. So we have liberty to operate the skull and put the electrodes in the dura itself also. So instead of having EEG, we having ECOG, like electrocorticogram. So it is more efficient and less noise. And human, we have either volunteer or pain patients. In this image, you can see this blue is the center of the coil, and the effect is maximum vicinity of the this dot. Later, the effect is diffused, both for the DLPFC here and both for the motor cortex. And this is my work in Japan I published. So this is the device my seniors there, they innovated and patented. This is to fix the monkey head, and so that monkey cannot move its head. You can see in different angle of this, and this axis, XY axis, is the for coil location. So every day we don't have to jumble with the stimulation area. Here we stimulate the motor cortex in monkeys, and we just put the XY axis and record every day and put the coil like this. Now, let's summarize it, how it affects the motor cortex stimulation with analgesic effect. So motor cortex is not only for the motor response, but it also is important in the sensory modulation and the presynaptic inhibition of nociceptive, that is pain receptive response. And neuroimaging study also reported the change, including my study. And I did my functional MRI with the subjects. And areas, if you ask me, cingulate area, insular area, orbitofrontal area, prefrontal cortices, thalamus, striatum. So all areas are somehow Some are that thalamus as the relay center, striatum is the connecting center, and insula is for the affective pain. Somehow they are involved in pain processing. Since the effect is diffused, so all components of pain somehow touched. Like insula and cingulate is very important for the affective and is the best treated by the TMS therapy. And though the spinal transmission is not very accurate, and as I told you, the DLPFCs also work, and I itself published the work that it is having significant difference result in the pain relief. Of course, the delayed effect and the synaptic plasticity, NMDA receptors, they are very pivotal. And these features are important for the cortical excitability changes. Somehow I didn't find in many my studies, but scientists found. And glutamate and GABA is responsible for the neurotransmitter release for the inhibitory control. And this is the paper published from my lab in the AIMS New Delhi. So we have reported the pain relief compared to the placebo or same treatment. Now the area I have already discussed. So this is the way you can see all there's so many points of pain in fibromyalgia, tender points. So that's why we don't have to worry about laterality. We just put the coil on the same side of dominant hand because the dominant is controlled by the contralateral brain side. And this is the fibromyalgia. There's a total 19 points. And people also earlier reported the motor excitability is altered in fibromyalgia. But in my study, I didn't find this also. And of course, I also find the cognitive impairment somehow, but they are not advanced cases, so they didn't perform well in mini mental score test or Stroop test I performed. Yeah, but I saw the improvement. And of course, like everyone else, I also find the pain relief. So what I did the neuronavigation to locate the motor cortex and use the EMG to have objective marker. So this is the detail. This is let us see the analgesic effect. So here you can see various area I discussed. So this is the DLPFC, the area I put stimulus, and this is the motor cortex. Most of the study did on this. So this solid dot is the result produced in the human subjects or patients, of course, and this dot is for the animal evidences. So you can see NMDA reported dopamine striatum is produced evidence from the human studies. Simply the authors are also noted here. You can see there's extensive evidence involving so many areas like cingulate cortex, and I have numbered earlier that human and animal model prove this thing. Similarly, we have the fMRI evidences also. And of course, there are some side effects. In my study, I noted that many patients tell they have some headache, and they have lost of sleep, some sleep excessively. And of course, if you put something on your head for 30 minutes, it will have some discomfort. Sometimes it will twitch the facial nerve or trigeminal nerve, so produce twitching and discomfort. And sometimes this clicking sound also having the noise sound. So same any magnetic device like MRI, there should be no metal implants. It can have potential to burn skin, but it is not reported. And of course, it's an electromagnetic wave, so it can artifact with the other devices like deep brain stimulation devices. So this comes to the last part, the future of TMS. Future of TMS, it seems bright. Now, earlier only AIMS and such prestigious institute having the TMS. Now it is coming to tier 2 and tier 3 cities. Standalone TMS clinic. Thanks to its wide area of reporting like psychiatric disorder and the psychological disorder and the neural disorder, people are getting fruits of this research. And best part is they have very less side effect, and it also prevents from the harm effect of the pharmacotherapy. So my floor is open for the question and answer. I hope I made some sense in TMS, and thank you for your patient listening. You can ask whatever you like. I will try to answer you with best of my knowledge. Thank you again, Team AIRSA, and my friend Ankit and Dr. Lal for giving me this opportunity. Thank you again.
Thank you, Dr. Tiwari, for the detailed presentation and also for the insightful and enriching session. And I think it's the right time to open this house for the question and answer session.
So this picture is clicked when I went conference, that is Janubet, Japan and Norway united for the brain education and therapeutics. So this is a very iconic picture in front of Kyoto University. This is the same tree. So I just wanted to share with you the pictures of my friends here in Japan. So you can ask question. It can be any question. Of course, I know most of the people are not aware of TMS or doesn't know much. But yeah, that's why we have such kind of session to exchange the knowledge.
And I request everyone not to hesitate because it's a great opportunity to learn directly from the expert of the this topic. So we encourage you to ask the questions, please.
And please ask. I am just a student like others, so I will try to answer. Maybe you can ask how much this machine costs. So I want to open a clinic. It's fine. You can ask.
Hi, Dr. Vikas, and thank you so much for the wonderful presentation, and thank you for accepting our invitation for such a wonderful talk. And hope the people have enjoyed such a kind of talk. And I have some one query because you have presented very well, but I'm also thinking about the some neuromodulation. So is it like the neuromodulation? If
Yes,
we
yes,
will
yes. Please kindly continue.
No, 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 no. Yes, I'm just asking that is it kind of
Yeah.
the neuromodulation?
Yes. Neuromodulation, you can see a class. So we can neuromodulation is the modulation of nervous system. So any method, like here I'm using magnetic stimulation, but some people also use transcutaneous nerve stimulation, and even the deep brain stimulation. They all are area of neuromodulation. So I have decided to move in the small segment of TMS. So of course it is a branch of neuromodulation.
Oh, thank you. Because nowadays people are nowadays people are thinking about the if there is some like the treatment for the neurodegenerative disease and some other traumatic brain injury. They are thinking about also for the neuromodulation. They want to change the neuronal activity and some mechanisms to ion channel also like that.
Yeah.
So yeah, thanks.
And yeah, let me tell you a very small but interesting thing in Kyoto. Maybe some people know that there is going to conference in Niigata in a Japanese Neuroscience Society. So the Fumio Fujiyama sensei, she is from Hokkaido University. So she asked me very good question. Can we stimulate the spinal cord also? Like, is there anything like spinal cord stimulation? That time I was unaware. But as Dr. Lal is very curious and interested about it, we have the TSMS, transspinal magnetic stimulation. So these research are going on to correct the spinal injury. As we saw, the TMS having a neurotropic effect and neuroproductive role. So in maybe in future, with the hard work of our scientists and the trials of our clinicians, we can find some good therapy to improve the life of the stroke or spinal cord injury patients. And I would love to work in this area. So yeah, this area is very promising, and still we have to know how actually this thing works. But yeah, we can see at least the effects.
Thank you, Dr. Vikas, for your insights related to that RTMS. It's
Thank you.
I listened it the first time, but 2 years ago I was working with little one physician with the fMRI. So
Yes, yes.
we are working in that thing. And I like your opinion how this repetitive transcranial magnetic stimulation is going to help in the pain relief and all the things. And these are all the non-invasive brain stimulation. It was such a very good talk. But in spite of that, I have some questions. Is
Yes, sir.
that rTMS, is it applicable only for the neuropathic pain, or we can treat like that migraine or headache or any
Uh,
fibromyalgia like that? Is
Sir,
it?
yes, sir. Actually, the first FDA approval is not for the pain; it is for the
Uh,
depression. But later study
uh,
found that it is very good in the chronic pain management also. So with
Mm-hmm.
saying this, it is low back pain and migraine, headache, and the
Mm-hmm.
fibromyalgia. In my lab itself, in AIMS, of
Mm-hmm.
course, it was pain
Mm-hmm.
research lab. So
Mm-hmm.
my PhDs and MDs, my senior to me, they published paper on the headache, migraine, low back pain, and they
Mm-hmm.
produces very strong evidence compared to
Mm-hmm.
placebo treatment. So not only this the psychiatric disorder, but yeah,
Uh-huh.
in migraine, low back pain, headache, all the pain disorders are somehow more or less they are giving the good results.
And it is it is location based treatment. Is it,
Yes.
I mean to my question is that it is particularly treat on the particular location with the particular severity, or we can take in on the any scale of the severity and we can treat with the any of the
Uh,
location.
This is very beautiful question, a very important one, and this is asked
Yeah.
while my MD Viva also. So yeah, here
Uh-huh.
in this TMS, we know that
Uh-huh.
effects is based on just below the TMS coil at the center,
Uh-huh.
but we see
Uh-huh.
that from simulation and other findings recording that
Uh-huh.
effects are diffuse. So for this, you can take my result. So usually it was told that for the pain relief, you had to stimulate the motor cortex and that too with the high frequency. And the senior PhD in my lab proved this thing. But we decided that we'll give stimulation to DLPFC because not only the pain but cognition is also affected there in fibromyalgia, and we give the low frequency. So contrast to motor cortex, we change the area, we change the
Mm-hmm.
stimulation paradigm, still we get the
Mm-hmm.
benefit of the pain relief and
Mm-hmm.
cognition improvement also. So yeah, till now it is not defined that for particular severity of disease whether we should change the frequency or intensity. I understood your question. We just follow the evidence. Like if I published paper in fibromyalgia, so I will go to systematic review. So yeah, most of the people found motor cortex better, but I think my patient didn't have any side effect, so I will go for the LPFC. So still we have liberty
Okay.
because
Oh.
in clinician purpose you just had to be careful about the side effects also, because
Mm-hmm.
otherwise people or patient won't be compliant to your therapy. So yeah, it is
Yeah.
now, till now it is not defined for which disease and which area is good. Yeah, but of course, since fibromyalgia is having a wide area of distribution, like they have sleep disorder, they have the nodes in
Mm-hmm.
their limbs. So we
Mm-hmm.
decided DLPFC instead of motor cortex because it is having relation with other brain center related to the pain perception, thalamus, somatosensory cortex. So we are just
Mm-hmm.
having a trial, but we found good result like this.
Yeah, one more last question.
Yes, yes,
Usually we see that some people have headache, so they take the paracetamol and crocin and
yeah, yes, yes, yes.
and after 30 minutes it
Hmm,
gone. Some
hmm,
people have taken they go for the sleep, and when they wake up there is no headache.
hmm,
My concern is that suppose the severity of the pain, if you can, because you are the expert, if you understand the severity of pain and you take it on the severity level from the 0 to 10, yeah,
hmm,
0 to 5, whatever you can think,
hmm.
then this ITRMS uh, treatment is required on the severity level on the from the 0 onwards, and it when it crosses from the 5 or 6. Is there
Yes,
any
yes, I
particular?
understood your question. Yeah. So
Yeah.
with this question, when I tell this that it has a relief in the pain moment, pain performance or pain
Mhm,
perception. So what I did before doing that, this my patients to the TMS therapy, I had their numerical pain rating scale test. So I asked themselves, just point a dot in this scale. What you feel that how bad your pain is. 0 is no pain at all, and 10 is the labor pain or the burning pain. Someone burn your
mhm,
skin. So, of
mhm,
course, in very acute and very harsh pain, it is not advisable because we see patient has to be lie calm and for 20 minutes at least. Usually it takes 30 minutes to all the setup. So if person is having so much pain that he or she can't even breathe, so first we have to give the strong analgesics like this paracetamol won't work, maybe opioids or tramadol. Yeah, in the subsequent session, we can have this TMS. Of course, this is not a contraindication, but if patient is cannot even take a breath and cannot stand or cannot sit, how he is going to sit for the TMS therapy for 30 minutes? So
Mm-hmm.
this is the it. So this is the long-term therapy, like you have the migraine headache.
Mm-hmm.
So when you have attack of migraine, so best therapies have medications because it is not preventable. When you have attack, you have painkillers. But other days you can continue with the therapy. So what was seen that gradually the occurrence of episode is decreased, and even though when evidence how to say when migraine occurs, the intensity is decreased. That patient is not having that much discomfort. So
Okay.
this is very good in the long term, and most important thing, it is free from the drugs. So any drugs somehow sooner or later they have some kind of side effect, and opioids are very notorious for the addiction also.
Okay.
Okay.
It means you can also is there find any numbness and tingliness or weakness related to that, which
Yes,
is
yes.
indirect. You can say is the indirect associated symptom with that pain.
Yes,
Am I
and
right? Right.
even yes, yes, and
Uh-huh.
even though in my study we didn't tell any patient to stop any medication, we use TMS as adjunct therapy, not a replacement therapy, because we don't know how much severe their disease is and what can happen if they stop the pharmacotherapy. So since pharmacotherapy is in both control and active, so it is nullified. So in both, of course, it is potential confounding factor. So the effect we saw is combined of drug and TMS therapy.
Okay. Thank you so much, Dr. Vikas, and you are doing really such a great work because nowadays most of the people are suffering with that back pain, sciatic
Yes,
pain, and spine pains. To hope your this finding and discovery will going to lead cost effective and long durability of the pain, and it will be accessible to most of the common people.
yes,
And
and the best part is this. Sorry to interrupt. This was found from WHO that
Mhm.
50% of one population is affected from some or another part of pain. They have
Okay.
yeah. So if we find something good, it will affect the half of population of the world.
Okay, that's a great thing, sir. Anyhow, our what we are doing, what we are research, anyhow, most it will be lead to benefit by the common people, which are not in reach of that high
Hmm.
types of techniques. So hope your finding and discovery in coming eras is going to help to the lowest people of the country. Mm.
Thank you, sir.
Okay, thank you so much for this great working and great findings. Thank you.
Thank you, Dr. Sarvam, sir, for asking these questions, and also thanks our today's speaker for explaining each and every question very nicely. So, thank you, Dr. Vikas, for this insightful and enriching session, and your experience and your expertise has provided us with deeper understanding of this topic. So, also, I would like to thanks all of the participants for your time, attention, and asking the questions. So I hope you all have found this session inspiring and valuable. So let's continue learning and exploring together. So thank you, and have a nice day ahead.
Thank you. So
Thank you.
in Japan, before we conclude any meeting, we should say Otsu kare sama deshita. So that means everything is done well. Thanks to all. So namaste and see you very soon. And I'd like to talk more and some other time. Then I will discuss result from the primate model, the monkey, how the results are different and what are doing in the monkey in Japan. That is my extension of work from India. So I think AISA will give me another opportunity to present my work in future also. Thank you again.
Yeah, thank you, Dr. Vikas, and you have accepted our invitation for such kind of talk, and it may be helpful to us also. So thank you so much, and thank you all to attend the participant. Thank you so much.
Thank you.